And we're live in 5,
4,
3,
2,
1.
Well, good evening, everybody. Welcome to our fourth and last Arthroplasty Triumphs and Defeats case discussion series of the year. And we're happy to have our sponsors, Dr. Sentinel. And tonight we have a very special guest that we're not sitting too far away from. Dr. Ziegler and I are actually sitting about 10 feet away from him. Just kidding. But Dr. Blumenthal is going to give us a talk on revision cervical arthroplasty, and it promises to be very exciting. And we have Todd Landman here, who I'm sure will have lots of comments. So take it away.
All right. If we can put my slides up or screen share me, or do I have to do it myself?
Just like we practiced.
Okay. Share screen.
He forgot. He's old now.
Here we go. Hey, do we have it?
That looks great. Perfect.
Okay. So I apologize that to kind of break the streak of guests and bad cases and good cases and things like that. But I'm going to do this in kind of a grand rounds format. And it really will, I think, satisfy the bad case, good case thing, because this is going to show the good and the bad. But it's been an interest of ours at TBI doing this for 20 plus years. We're starting to see more and more revisions, just like our total joint colleagues did back decades ago when they started putting total hips and knees in. And then about 10, 20 years later, they kind of had to figure out a strategy of what do we do to revise them? And, you know, any operation is going to have a finite incidence of revisions. So I'll start with the normal stuff. Oh, it's slow. It worked before, Corey.
Got using the arrow.
There we go. These are my relevant disclosures. I'm going to talk a bunch about all four of these discs. I've consulted and taught on all of them, some currently, some previously. So I am equally conflicted amongst all the cervical discs for the most part. I'm not going to spend much time bragging about how ADR has blown away ACDF as the gold standard for cervical disc disease. It's pretty much the most studied of the orthopedic / spine devices in history. So what do ACDFs like to do? You decompress the cord and the nerves, you restore disc height. Well, TDR does that. But what's the negative ACDF is adjacent segment disease. And I think it's reasonably well established at this point that TDR at least slows that down. So let's lay the predicate of what the market is. And the market probably is more driven by patient demand at this point, because all of us in our communities see a slower adoption than what we would have thought. And this is one market analysis, and this is the very august medical journal Becker's that a few months ago, and I kept this, projected a $7.8 billion market by 2030 with a compound annual growth rate from now until 2030 of about 18.5% per year. So economically, this is not something that can be ignored. So we've seen that cervical TDR is more accepted and has gained more acceptance as an option for treatment than lumbar. And we're going to focus 100% tonight on cervical. It is inarguably the most evaluated spine treatment based on, and you'll see some of the data. We've got studies, IDE studies, systematic reviews, meta-analyses in almost every continent, well, not in many continents in countries in the world. And the worst study shows equivalency, and there's really no literature reporting inferior results, and most literature reports superior. And this is what I'm talking about. It's like 1,200 articles plus on cervical arthroplasty. And that is a robust literature. I love this slide, and you know, I show it, and again, it's not 100% relevant to the topic tonight, but this is a slide that we show at a bunch of our talks that compiles the data in NDI, which is, you know, very well accepted outcome measure for cervical decompressive surgeries, looking at the IDE studies, disc to disc, data is even included in this. So the results are very reproducible. You can see they're all multi-center trials. They're different centers. And the upshot is there's a very uniform or uniformity of outcomes in all these trials. In 2020 alone, there were 16 meta-analyses published on cervical TDR, 7 on clinical outcome, 3 on HO, 3 hybrid, adjacent segment, and center of rotation. So the journals feel like there's enough impact factor to publish a lot of stuff on disc replacement. And the reality is that the studies really found superior or at worst equivalent results in really all these outcome measures. We've never seen inferior results. So now let's go to the topic tonight. And that is, with any procedure, there are going to be failed cases. There's going to be revisions that have to be done. And we've learned this from our total joint colleagues. So, you know, the purpose of tonight is to kind of analyze maybe what the incidence is now and what it might be in the future. What are the most common mechanisms of failure? And then what do we do to treat them? And so, you know, common modes of failure, and I'll come back to this a couple times over the next 40 minutes or so, include migration, subsidence, adjacent segment doesn't go away. Heterotopic ossification was a more prominent early concern, maybe a little bit less. Osteolysis seems to be growing in interest in the field. Reasons for failure: patient selection, technique, device, and then father time. We've learned from our hip and knee colleagues that with time, eventually revisions will need to get done. So one of the things that's been a difficulty has been determining the incident rates of failures. Why? Most of the studies are case reports or small case series, and then variations in the definition of what constitutes a failure, and we'll go over that as well. Failure rates are best determined from large clinical series or registries with multi-year follow-up. That data is difficult to obtain, even in certain countries' registries. There's bias because there's preferential reporting. You can analyze large insurance databases, but again, this is lacking in details. Clinically, it's more economic stuff. So, this has been a database that we've tried to keep very tight at TBI. These are just our cervicals over a 20-year period. You can see that, and this is by surgeon adoption, we're starting to see more surgeons at TBI adopting the technology, but at this point, it's still a smaller group that has really embraced the technology. But what it's done is it's allowed us to gather data from a case series that's large, that has follow-up, and is fairly self-contained. So this was an early study that the three of us and Donna did, looking at some of the first IDE trials. We were in 136 patients, and we looked at re-op rate, and the re-op rate was less statistically significant, although high. And this is early in the learning curve, and you'll see that learning curve does make a difference. And adjacent segment was trending in the right direction, but the study was underpowered to really substantiate a difference. What we could see was that based on some Kaplan-Meier survival analysis curves, that the revisions with TDR did occur significantly later. So the devices, lasted longer before, we started to see failures. So how can we get a rate so that we can compare not only with other series, which there aren't that many in the world, but we can compare with the hips and the knees and the shoulders and the ankles and all that stuff. So we looked at all of our patients in that database that you saw a couple slides ago with at least 2 years follow-up. So we basically have 2 to 20-year follow-up of 1,600 cases. And we include everything, one level, multi-levels, and hybrid. And we utilize the FDA guidance document for the preparation of IDEs for spinal systems to define removal or revision. I won't read them here, but you can see them. And based on this data, we were able to get a rate of revision, 24 cases or 25 devices. So just under 1.5% revision rate and just over 1% revision rate per device. So we've really got something now to kind of hang our hat on. Obviously, between 2 and 20 years, we have to kind of be more granular and see what about between 10 and 20 years and longer follow-up so we can really compare to the hips and knees, but we will get there. So we started to see some failures, albeit at a very low rate. And so we wanted to ask ourselves, or we did ask ourselves, well, how can we best evaluate the mode of failure? Well, by modes, we can actually add in the cases that we didn't do that were referred in and get a larger N of revision cases to just look at why these things are failing. So we did another study where we added additional amount of patients so that 40% of the patients were outside implanted from TBI, 60% were our own. The demographics were similar, between the groups and are not inconsistent with what we see in a cervical arthroplasty population. And we looked at how we revised them. So 31 of those 42 patients were revised to fusion, and 11 of them were revised to another disc, one by repositioning, one was actually to another disc replacement, which is kind of a whole nother literature in itself that we can talk about later. The surgery can be done safely. Obviously, in contrast to lumbar revision surgery, it's still a revision. It's still, a case that you got to pay attention to, but it doesn't have the hazards that a lumbar revision case would have. And all of them were kind of done as they were planned to do. So we look back on those 40-something cases, and what did we find? We found a lot of cases, the predominance of cases, were severe osteolysis with or without C. acnes. So that kind of popped out at us, and we're going to look into that deeper in a moment. Other things are a lot of technical issues, subsidence, we can look at that. Posterior cervical, we're starting another study just looking at the need for posterior foraminotomies after arthroplasty, which was a common mode of failure in the Rush study. So we need to get some data on that. Metal allergy, we're seeing a bit more frequently, and other things that are technical or indications. So, revision surgery index level. So this is a systematic review. And like I said, there have been a bunch of them published. You can see the final author on this is Dan Rue, who we all know. And, they found the average for index level re-op rate of 3.9%, a bit higher than ours, but certainly not out of the ball game. Reasons, progressive symptoms, ongoing neck or arm pain. To me, that's not a diagnosis, and we tried to do diagnoses on our analysis. That's just symptoms, and you're kind of guessing that it might be coming from that. But they had other situations as well: disc subluxation, deformity, fractures, malpositioned implants. Another study from Asia looked at the single site and found a 2.7% revision rate. Again, not too inconsistent with what we found at our site at TBI. Again, indications were probably their number one, and they had a reasonable number of osteolysis as well. This was, and I'm going to kind of take a step back on the MAUD database, and I'm going to refer to it later. But this was looking at the MAUD database for revisions as well, complications, et cetera. This was the top 5 complications from the MAUD database: implant migration, technical problems, neck pain, again, not a diagnosis, a symptom, HO, radiculopathy. Now, to kind of dive deep on MAUD, the MOD reports are really helpful in identifying types of complications that occur with implants, but there's no denominator to really say what the incidence is. There's no way to ensure that all complications are reported, and some are not clear how they're defined, and the severity of HO is not defined as well. But we'll come back to that because there's some interesting data that can be gleaned from the MOD database. So reoperation. So an important factor in evaluating safety of an implant is what's the reop rate. And we can look at that in other situations as well. So this is from the Simplify study. Their reop rate at 2 years, 2.2% compared to ACDF. Again, learning curve kind of patients, 2.2 probably is a bit high for 2 years, but some of the surgeons were earlier in their learning curve. Other studies have found similar, significantly lower reop rates with disc replacement compared to fusion. And again, and this is a repeated kind of situation that there really isn't a lot. There is no studies that show higher reop rates. So at TBI, during our 20-year history, we've learned a lot. Studies that we mentioned earlier, when to opt for ACDF. So the indications, I think we're getting better. We're certainly having less intraoperative conversions. And I think that, creates a cost-effective and clinically effective and good for patients kind of scenario. But, again, we're going to talk about failures and what are they related to? Surgeon technical error, including patient selection, biomechanical, biologic, now that we've kind of come, a little bit more full circle looking at osteolysis and metal allergies, migration, and then other reasons that failures occur. And the fact of the matter is, and we've got a lot of people listening that perform cervical TDRs, you need to be aware, you need to monitor your patients, and then have a strategy to address these failures when they do occur, albeit at a very low rate. So again, reiterating, our failure rate just under 1.5%. Hips and knees, this is a recent study from the UK, obviously a whole lot more numbers than ours and a whole lot more years of follow-up. But these are some benchmarks we can look at as we start to gather 10 and 20-year data. The early data does look pretty favorable, I have to admit. So let's look at some of the reasons why devices may perform suboptimally. So the first thing I'm going to focus in is on size. And we'll look at implants, we'll look at height. There's some studies out there. Footprint mismatch, this study seemed to indicate and concluded that it could lead to subsidence, certainly undersized, loosening, HO, incorrect center rotation, and then facet joints. And we'll look at that a little bit closer later. And what I'm going to do tonight is intersperse some of our own cases, since we're here to show some challenges in arthroplasty, and this is one of our own internal cases. And this is a disc that's no longer on the market, but the surgeon here chose to do a PCM, and PCM had some challenges both technically and in size selection. And whether this device was just too big to begin with or displaced anteriorly, that's not the kind of result that you'd like to see. And it was replaced with the ProDisc C. And we all know now that there are next generations, and I happen to like to call the original ProDisc the OG. And as we transition to the new ProDiscs, I would not throw away this prosthesis. This is an excellent revision prosthesis. It's an excellent primary prosthesis. The data on it, 10, 20 years is incredible. But this is an excellent, excellent, excellent revision prosthesis. The robustness of the keel in a situation where the disc's already been mobilized a couple of times gives you a little extra security. All right, well, let's go back to a footprint mismatch. And this is another study from Asia. And, this was Prestige LP and Discover. LP is available in the US, the Discover is not. And, they looked at and felt that HO might be increased. And again, HO was a big concern at the beginning. And I think those of us that do it a lot see it less and less. And whether or not we've learned some techniques to decrease it, or whether it's not just that big a problem, at least in the short term, remains to be seen. Here's another one that looked at over distraction was related to HO. So disc height is important, too short, too tall. Here's an example. So here's a lady, and I put it in the disc height section, but there's kind of multiple etiologies. And she's a 2-level. And you can see on the extension film that 6'7" is a really tall disc. In fact, it was a 7 millimeter that I don't know that I've ever used with the Mobi. I didn't see that it's pretty hypermobile, although I did not measure the angular deflection there. But the upshot, she was symptomatic. This was a little early in our series, so we're still considering all the options, and we kind of thought ACDF would be the gold standard. But a lot of these patients had the disc replacement in the first place because they didn't want a fusion. So she was revised to the old ProDisc OG with an excellent result. Prosthesis, very secure, very stable. So the hypermobility went away, and it didn't seem to be as over distracted. Put in a shorter one. This is a biomechanical study, which really doesn't tell us anything we don't know. If you over distracted the space, it distracts or could sublux the facet joints and potentially lead to degenerative change or accelerated failure at that level. This is a study that Rick Geyer was the author on, and this was based on the data, the radiographic data for the Simplify study. And what he found, and it won the CSRS best paper or third best paper in 2021, is that a lot of these disc heights are less than 4 millimeters. And until the Simplify came out, there was not really a 4 millimeter disc. I think one of the other reasons we're seeing more 4s being used is we're treating more spondylotic segments than when the technology first came out, and we're pretty much just studying fresh herniations in a younger population. But the 4 millimeter height became available after the start of the 1-level trial, and then for the full 2-level trial, and you can see it was used a significant amount of the time. And I can tell you to this day, in my patients, particularly females, smaller statured, I'm using a lot of more 4s than 5s these days. So it's been there. So here's another one: sizing and positioning. Multi-source failure. Patient became symptomatic or didn't resolve their symptoms after this particular procedure, oversized. And MRI didn't really show much. So, it's simply a single disc problem. And what we've learned is that the Mobi doesn't destroy the end plates very much. So it's a perfect disc to do a disc-to-disc revision. And this was a smaller female. So this was the revision that we did with a Simplify, which again is a pretty good revision disc as well as primary disc. The results are very good as well. And so that's when we use there. As we know, positioning is more important with a disc replacement than an ACDF. Here's one where positioning mattered. Again, pulling up the skirt. This is one of our own cases. And this is a patient with a unilateral radiculopathy, had a ProDisc placed, went home, and had a contralateral radiculopathy. And it looks like the disc on the post-op film looks a little eccentric. On this one, it looks way eccentric. So obviously you're concerned with impingement of the nerve root on the contralateral side. And in fact, there you can see that it is impinging in the neuroforamen and should be revised. Now, we didn't think at that point you could revise a keeled prosthesis, but in fact you can. And you can see here and here, we actually bone grafted the original keel site. And that patient resolved his contralateral radiculopathy, pre-op, post-op, and ultimately did well. This was our repositioning one from our revision series. So here's another one for positioning. A 39-year-old female, 2-level Mobi, and this was done not at TBI, but referred in. And so a very sophisticated patient who looked at the x-ray with the doc and said, that disc doesn't look right. Did a myelo-CT because she was having symptoms and was told that the disc was placed within a millimeter of the spinal cord. So she came for a consult. And yeah, it looks like that disc is a little posterior at C6-7. And again, this is one we were able to revise. There's the Milo CT she came in with. And here's one we were able to revise with the OG Pro disc. On the lateral, the 5.6 looks okay. In retrospect, there's some subsidence there. Probably should have considered revising both, but she's doing okay. So there's no reason to do so. Interesting study from, I guess, special surgery. I see some special surgery names on there that basically seems to indicate the better you position the disc, the better the outcome measures. So kind of what we think is you want to position the disc, within a millimeter of the posterior border and as close to the midline as possible, you're going to get better. You're going to get better results. Let's talk a little bit. And I looked at hypermobility and I kind of showed a couple of cases, but there's actually been a little science done here. And this was a really good study presented by Pat Warden at the 2022, last year's NASS meeting. And I think either Rick or Jack participated in this as well. And it tried to biomechanically define what hyper and hypomobility is. Whether or not this is going to become gospel like White and Punjabi's instability criteria, I don't know, but it's a good start. And I've started to use it when measuring patients who come in with symptomatic discs. And here's another one, and hate to pick on the Mobi, but it is the most prone to hypermobile motion. And you can see here, definitely more than 16 degrees of hypermobility there. So this was another one we revised. There was also disc disease below it that was considered to be done the first time. I don't know why the surgeon didn't do it, because there was a herniation below. So when we revised 5.6, we implanted a Simplify at 6.7 as well. So here's the good news. When I looked up migration displacement, none of these are our cases, so I had to go to the literature for that. I'm not hiding anything. But in the literature, there are some more disastrous migration type cases, and this is one from Asia, and it shows a posterior migration, and they felt it may be related to pre-op kyphosis. I do not have the pre-op X-ray, but it was in this. I'm sorry, and this was revised to a fusion. Here's another one, and this one's a little bit more of an enigma. That's a good-looking hybrid. You know, you've got a prosthesis at 4.5, an interbody fusion 5.6 looks great. Why this happened, I don't know. They say no traumatic event, but the upshot is the core came out, the end plates came out after that, and it had to be revised to a fusion. Here's another case of extrusion, these authors suggest a long time ago, 2009, that hypermobility, ligamentous laxity should be considered when you're evaluating patients for arthroplasty, and I don't think that's an unwise thing. All right, well, let me move on to metal allergy, and we seem to be seeing it more often, or rather, we seem to be asking the questions more often. But we need to consider that. So this was another patient from elsewhere that presented with symptoms after a 2-level arthroplasty and was diagnosed with a nickel allergy subsequent to these things being performed. And, reasonable implantation. I didn't measure it, maybe a little hypermobility, but, I think in someone with a documented nickel allergy, you're pretty much obligated in this situation to revise it. MRI didn't really tell us a whole lot. And, again, what do you do? So in this case, the simplified disc, which is a Pecon ceramic with a thin type pure, commercially pure titanium coating, doesn't have any nickel, and it's something that can be used for a nickel allergic patient. And use the post-op. All right, well, I'm going to spend a little bit of time talking about osteolysis because it's become increasingly higher profile in the cervical arthroplasty world. So I thought I would start with the definitions, the NIH definition. was process of progressive destruction of periprosthetic bony tissue on serial radiographs, particularly cavitation. One of the more interesting modes of failure has been this. We started to see this, more frequently and seen reports of it from both US and outside US. And our little addition to the world is we actually, unlike the outside US, started culturing these patients for C. acnes, letting them brew for 2 to 3 weeks. And we seem to be seeing a relatively high incidence and association. And hopefully we can discuss at the end what we think came first, the chicken or the egg. It's a problem. We see it clinically. We also see stress shielding, and we've got to be able to distinguish between the two and be able to come to the accurate diagnosis. Some discs seem to be more at risk. Maybe it's the PCU we see, maybe it's some other material. So there's this a great review article in European Spine Journal that tries to differentiate and distinguish and categorize bone loss, stress shielding, whatever, versus pathologic osteolysis. And in their systematic review, they found that periprosthetic bone loss, remodeling, very common, osteolysis less so. Bone loss early, remodeling early, osteolysis late. Remodeling, no need to intervene. Osteolysis, they recommend reoperation. We don't necessarily recommend it in every case, but certain cases, yes. And then looking at the causes are things that we've been talking about in our conferences as well, and we'll get into them a little bit more. Sometimes there's treatment challenges with osteolysis, and because some of them are asymptomatic. And here's a case it's actually one of our IDE patients at TBI that had this prosthesis put in for cervical radiculopathy at C5-6, and the patient did great. Follow-up, they did great. They had a little flare-up around 3-4 years. We did an MRI to make sure it was okay. No problem. But you can see here on the X-ray, and we were just learning about this at the time, so we didn't quite know what to do, is potentially these periprosthetic cysts. And patient came back. They seem to be getting worse. I apologize, but for some reason, I didn't put the CT scan in there. The CT scan was a lot scarier than this. It was definitely progressive on CT. And I will show some CTs later of typical osteolysis. But in this case, I just didn't put it in. The device was explanted in one piece, and this is kind of a repeated thing that we see. The weak part seems to be the polyethylene strands, which are the annulus reconstructive type things of this disc. And it looks like it looks like they fail. They start to show some shear at first, and then they fail and potentially cause wear debris. And in fact, all of these cases that we've seen, we revised to fusions. We haven't done any disc to discs on osteolysis. And in retrospect, probably a reasonable thing to do a fusion, because they tend to have kind of predominant cysts that you have to curette or burr out, and you kind of mucked up the end plate. And then the association with infection, may not be the best idea, but it's certainly associated with wear debris. And this is just on this case. We need to have many more cases looking at the possibility of wear debris. Here's another case that we did at TBI that is actually Alex Sattin's case, but it was referred in. It was done in Europe. Patient did well for a while, which is what we see, and then sought treatment by a chiropractor who took some x-rays and said, you need to go to a spine surgeon. I'm not going to treat you. And what do we see here? Number one, in the middle disc, where's Waldo? Where did the PCU implant? Where did the core go? And on the CT scan, this is what we see, these huge periprosthetic cysts. And that is just absolutely pathognomonic for osteolysis. So I was there when Dr. Sattin revised it, and that's where that core was. When he exposed the front of the spine, it was sitting right in front. Easy to see, easy as day to see. And, unfortunately, this patient required a 3-level revision. This is what the implants look like when they came out. Again, the polyethylene strands seem to not do so well. And because it was 3 levels, he elected to do posterior fixation as well. And interestingly enough, it cultured positive for C. acnes, so he continued antibiotics for 6 weeks. We sent these to an independent lab to assess the wear characteristics. And these are some of the early reports we got back, and we're just at the beginning of studying these things. But it's good to have somebody independent looking at these things. So osteolysis, is it device or design related? And I'm coming back to the MOD database because, again, I'm not saying there's a denominator here, but we decided to look for each cervical disc type for 20 years and what percentage of the reports were for osteolysis. And I'll put this up there for no other reason than, you can take it with a small or large grain of salt, but it looks like one disc is a bit more prone, or maybe that's an understatement, a lot more prone to osteolysis in terms of their percent of failures. Again, no denominator here. This isn't saying 30% of M6s have osteolysis. This is 30% of the reported failures are for osteolysis. This is kind of a landmark article from Matt Scott Young. We've seen this before. This is his Australian series. It's much like ours, where he just looked at all his revision cervical discs. His overall revision rate was 3.3%, not much more than ours, but 30% of the M6s were revised, predominantly for situations like this, which would be osteolysis and material failure. None of his were for infection, and they were treated with fusion. Our experience with the M6, total 34 patients, reoperate 8.8%, but the ones 5 years or more, which was kind of what they're talking about mid to late term, 23% as opposed to no early osteolysis cases. So it does appear to be a mid to late term phenomenon. In Matt's article, he talked about the biomechanical testing that is done on these implants, and the elastomeric implants undergo the same testing as the ball and socket, and that might not be the best testing material. I am not the expert to discuss this. I've talked to Lisa Ferrara about it, and she's much more well-versed on this. But in Australia, they require a package insert that does warn of periprosthetic bone loss, may be indicative of osteolysis, kind of a warning label. Another article, and this was the ORS, and subsequently presented Spine Week, another series from Australia, smaller number of patients, 86, but a lot of, 86 M6s more than Matt's. And they found a 40% incidence of osteolysis. So, again, is where there's smoke, there's fire. I don't know, but we're getting a lot of data here. Certainly further study needs to be done. The relation to, does infection cause the osteolysis, or does wear cause the osteolysis and activate an otherwise quiescent colonization? We can talk about that because I'm going to try to finish early. We just need to be aware and have a treatment strategy. So the questions I would ask is, can we agree on the difference between physiologic remodeling and pathologic osteolysis? I think we now can. Is it associated with failure and wear debris? I think so personally. Why does there appear to be an increased incidence of C. acnes? That question kind of is still needing to be answered. The general spine, the deformity of the revision world, and Jens and Izzy can talk about this more than I can. They've even defined, this C. acnes colonization / infection. They've kind of given it a term now, UIPC, unexpected intraoperative positive culture. You can see 24% adults, 43% pediatrics, but go down to the conclusions, and there's not enough data to really know what to do with a positive culture when there's no obvious infection there. So we're still trying to learn. Interesting enough, there's another article I just reviewed for European Spine Journal that came to the same conclusions with similar numbers from Europe. Dan Rue is also published on osteolysis, and has his own conclusions, but it's definitely, again, on the radar screen. One last thing, it can sometimes present by dysphagia, sore throat, and the ENT can sometimes, in one of our actual revisions, in one of our IDE patients, we actually found the osteolysis because he was having ENT problems. Fortunately, not this massive here, but ours was not dissimilar, just a smaller magnitude. And you can see the osteolysis on the X-ray. So, obviously you got to be suspicious with radiographic changes. Minimal osteolysis is not uncommon and often not clinically significant, but you have to follow these patients. And we strongly recommend yearly X-rays. And if you're at all concerned, do a CT scan because that'll define it kind of better than everything. It can be treated with removal and ACDF, and I don't know that the antibiotics make a difference if there's a C. acnes infection. I think it's just curating the cysts and creating the stable construct of an ACDF, because we've used cages and plates and we've not had any recurrent infection or clinical infection. Certainly it's rare, maybe not so rare with certain prostheses, but it does occur and is a problem. And, when should you intervene? That's something we can talk about as well. This is kind of our treatment, paradigm right now. You see a suspicious X-ray, we get an X-ray. If it's asymptomatic osteolysis, we observe it if it's mild. If it's not a stable platform or progressive, then we would revise. And if it's symptomatic, we would revise. And at the time, always culture for C. acnes. Again, I don't know what we're doing with that information except gathering it and hopefully making the literature smarter and ourselves smarter. So, coming to an end. Revision of cervical artificial, this is rare, we've seen that. Anterior removal infusion is the most common treatment. Obviously, if inadequate bone stock, you may have to do a corpectomy. We've not seen that, at least at our site yet. Posterior sometimes. Revision to a disc is possible and may maintain the advantages of arthroplasty. And I think that's a really intriguing thing for us to talk about. Prevention, patient selection, technical, choose the right implant for the right patient. A hypermobile patient shouldn't get a hypermobile prosthesis. Our revision rates at this point appear to be favorable to the hip and knee literature. Disc to disc, again, I think it's fascinating. Good end plate, no gross infection, no advanced osteolysis. And many times the patients say, if you can give me another disc, that is what I want. I do not want a fusion. So that's good. And I'm going to end on this study from the August Neurosurgery Journal of Turkey that studied ACDF revisions and arthroplasty revisions and found that you can do either one with similar complication rates and that it's safe to do a revision cervical arthroplasty. So if you go to Turkey, they've bought off the Kool-Aid too. I'm done. Thank you.
Scott, that was a great overview. Thank you very much. One question I want to ask you, or free to make the point. You said that you have to follow these patients, and I just want to clarify because somebody posted on the chat room. It's really, really important that when you have these discs is to compare. If you see any change at all, always compare with your original post-op, because the changes can be very, very subtle. And as Scott said, a lot of these osteolysis patients are asymptomatic. And if you don't look at the original x-rays, you might think, oh, everything's fine. But if you look at them, you start to see some subtle changes. That's when you should click and get a CT scan. And as he said, they may be asymptomatic. And if they're not compromising the bone significantly, then you can follow them, but still understand and explain to the patient that you got to follow them closely.
Yeah. Bob Wang asked about Vanco powder. Do you guys use that in revision deformity cases, Vanco powder? Because I know that we've gone back and forth. Like some people use a TBI, some don't for revision cases. I've not used it in cervical. I know Todd tends to dip his prostheses in antibiotic saline, correct?
Yes, I've been using vancomycin, and then at the time we talked last, I washed the wound with vancomycin irrigation, and then I soaked the implants prior to implantation. I also now and I'm doing a study, I'm in the middle of a study now where every cervical case, when I remove the disc, I send it for culture. And it's shocking. About 40% of these patients so far, I have about 40, I want to get 100, are positive for CACs. So now it's like, now what? I mean, because that means this, you know, and it's been published before that it lives in discs. So that now, you know, as I explanted it, and there seems to be a correlation with the more degenerative the disc is, the more likely you're going to have CACs in the culture. So what I've been doing is that technique, but I also have been placing vancomycin powder in front of every implant with no issue. And I've been doing that for quite some time now. So I just layer it around there, and that's not been an issue. Just
You do that on your primaries, Todd,
Yes, I do.
not just revisions?
Correct. Yeah, I'm doing that now because what I'm finding on these cultures, it's been shocking me.
It's, you know, that is very scary, Todd. And people have reported, you know, I think the original literature, when they're doing discectomies, they would culture them before and after. And, you know, there was contradicting information, but many of them did find a high incidence of C. acnes. And I don't know what to think about this bacteria. Maybe it's just it's one that sits around until the environment is fine, and then it starts to multiply and cause infection when there's another reason.
Yeah, and I think possibly with M6, as Scott was mentioning, you know, the polyethylene weave, the fibers, that's the failure mode, I believe, like you all do, because usually you'll see the PCU, the polycarbonate urethane core, intact, because high molecular weight polyethylene is great for tensile strength, but it doesn't resist shear at all. And so when you're putting M6s next to fusions or stacking or putting them in people with high slope angles at T1 slope angle, giving you sort of like a sacral slope angle, for example, you're putting a lot of shear on that implant. And is that causing early poly failure and then wear debris? And then is there a nidus of C. acnes that's been sitting there that then ignites? I don't know. It's just an interesting conversation to have.
Yeah, you know, that's the chicken or the egg that's got us talking about it, and it's fascinating. And I think most of us do think that it's the inflammatory soup that, you know, is a nice haven for the C. acnes. And I think that the inkling for that is that otherwise, you know, a good deal of the revisions should get re-revised if it was really a virulent organism, since it's sitting there in 20 to 40%. And you know, we're putting another disc in, then you would think that those would develop osteolysis, and we're not seeing that, although it's, you know, relatively short term. But I think that's probably the best hint that it is an opportunistic bug. It just, you know, it's sitting around and it's just looking for dinner. And, you know, when the inflammatory soup is there, it's dinner time, and we can culture it out. And the other proof is that a lot of times when we'll do revisions and just put the patients on some oral antibiotic for a few weeks, you know, there's no issue from it. So, you know, fingers crossed that that's what more time is going to tell. But I think it's reassuring that we're not revising revisions.
Right.
And, you know,
I'm sorry, go ahead.
And what's fascinating to me is that with the patient that has multiple level M6, one will get infected, like Scott showed that one case where the middle one terribly infected, the other two look fine. And you say to yourself, what is so weird about the one disc that it gets infected? And I like Jack's analogy. I think that's a good way of looking at it, that, you know, maybe C. acnes is there all the time and it's just waiting for the right milieu, so to speak, before it multiplies. But why do you think it's just one? Scott, Jack, or Todd, any idea why you see it in just one and you don't see it in all of them?
You know, if you have 3 discs, maybe all 3 don't fail. You know, I don't know.
But, you know, is it?
And I do think it's
biomechanics, or, you know,
yeah,
what do you think?
I do think it's an inflammatory, obviously. I think it, you know, obviously wear induced macrophage reaction causing the periprosthetic cysts, you know, why they're activated at one disc than the other. And I think, you know, Bob Wings asked the same question. Would you consider prophylactically just revising it, do frequent follow-ups? A couple times where it's just been one, I just revised one, and I'm following it very closely. And then I had a patient come in who had heard about this and said, do I need to get this revised? Did a CT scan? was perfect, no osteolysis. I said, my recommendation is no, just come back for once a year x-ray and we'll keep an eye on you.
That's what I'm doing as well. Yearly x-ray.
Yeah.
If I see some end plate rounding or slight posterior end plate cystic formation, I do a CT,
Mhm.
and you'll identify an issue.
Jens, you have your hand up?
Yeah, just wanted to, first of all, congratulate Scott on an incredibly helpful macro perspective. So you've started us on disc replacements, and you're also providing very impeccable guidance in the long run, and critical analysis is part of a success story. So thank you. So just about Cutibacterium acnes, this is obviously something that's really compelling, and if we can learn something from it, from our shoulder arthroplasty people. And I had the great privilege of working next to Dr. Rick Mattson, our erstwhile chair at UW, who's a renowned shoulder arthroplasty surgeon. And this, as you know, is basically a habituated atavistic. I mean, this came from the beginning of evolution. It's one of the oldest bacterial organisms we actually have in human life. And it actually lives in our sebaceous cysts. It's in the sebum. So it's way down. This is not at all affected by skin preps of any sort. So you kind of burn off the because as you're laughing. So this is
Sure.
lives in us.
Yeah.
The problem of studies has always been that it's easy to contaminate, and also as easily overlooked. And its pathological meaning is very difficult to understand. It clearly, when it hits the bone implant interface, can grow like a Pac-Man along it. And so osteolysis is known, protracted wound range is also something, but because it's literally living in us saprophytically, it usually does not make us septic. So I just wanted to extol a little bit on that, but the real problem is that it's so deeply ingrained in the soft tissues that it's not really sterilizable. So I think soaking antibiotics like what Todd does to give me food for thought, silver sprayed implant coating, things like that might be an issue. The correlation of disc herniations and opportunistic Cutibacterium growth has also been explored in Denmark, and that study came out very positively for these opportunistically grown things, and that was in 2013. I know the senior author was a guy named Christensen. I don't know the others, but it was in European Spine Journal. I could try to look it up. And again, the study was like shocking because he said, give antibiotics and you can cure back pain. And it in the end was, again, just one of those questions of how do you really meticulously sample this tissue so that it's not getting contaminated on the way in or out, and how this gets air sealed, because it's an anaerobic but aerobic tolerant organism. So this is a amazing thing, but I think maybe we should kind of close up with our shoulder arthroplasty doctors, maybe Dr. Mattson, who's worked with Dr. Pottinger, who's a great colleague at UW, to give us more insights in this organism. As to the implants in question, I have every reason to suspect that this is an ideal nesting place for this particular bacterium.
No, probably.
Yeah, and even though it may be very prevalent, very common, Jens, perhaps in every wound, it just seems that, you know, the one implant seems to be its favorite place to grow. Because
Nesting, multiple little crevices, magic weave.
I've worked with John Inamura here and Grant Garrigo's shoulder arthroplasty surgeons, and I did a 2-level cervical pro disc, and on a friend of mine, and he had trouble swallowing. And I went in and he had some scar around his esophagus, and everything looked normal, no osteolysis. I cultured in front of each disc, sent it off, closed them up, and it grew C. acnes. Turns out he had a shoulder replacement also several years before. His shoulder's always been aching. So I told the shoulder, then I know I revised infusion, but my shoulder surgeon went and scoped it and did a scope biopsy, and his shoulder replacement's growing C. acnes too. So this stuff's everywhere. It's really tough to do. So the shoulder replacement guys will sometimes pre-treat patients with 3 weeks of doxycycline. And then, you know, when I do these and I get a positive culture and I'm putting an arthroplasty device in, I've been treating them for 6 weeks of doxycycline. I don't, you know, there's no algorithm. I don't know what's right or not, but I'm just doing that. And then I follow them. So far, it's a non-issue. The last thing is that I know the shoulder placement, they will do at least 5 biopsies around And if it's only 1 or 2 positive of the 5, they consider it a negative or they don't really treat. If it's more than that, but it's harder for us in the cervical to get 5 biopsies around a disc. It's not as big a joint. So that's also something to think about. It's really complicated.
Hey, Scott, this is a great discussion, but I wanted to ask you a question. So now that cervical disc is being adopted by so many other surgeons and we see the uptick, and you showed the graphs whether or not Becker's is right or wrong, I think that we're going to see more and more patients needing revision because of an inadequate decompression. And a case in point is I saw a patient with cervical stenosis where I don't know what kind of decompression they did. In the note, they said they did a decompression, but it was all bony decompression. And the poor patient still has myelopathy. So what's your take, and Todd or Jack, about, we know we have to do a meticulous decompression, and what we have to do is do a better job than if you're doing a fusion, but
100%.
It's definitely not as much fun when you take out a prosthesis and have to dig through the scar to re-decompress the cord and the neuroforamen, but it's doable.
Yeah, it's doable. It is more complex. And I've been asking the companies, sometimes when you explant, if you explant a 6 millimeter, you're going to lose a little bone and then you need a 7. Well, okay. So there's a few companies have 7s, and then then the only company that makes an 8 millimeter tall is Prestige LP. So you can get an 8, but what about a 9? If the patients, many of my patients, as you mentioned, Scott, they want another arthroplasty replaced if they have an issue, inadequate decompression or failure. And sometimes as you pull out the implant to decompress further, you want to re-implant, but you need a taller, bigger implant. So
yeah, my concern would be if you got to the point where you're looking for an 8 or 9, probably don't have much end plate left, and then you're into that cancellous vertebral body bone, and you're risking more subsidence.
Yeah, I know we all talk about that, and I use, like we talked about size, and I think I always use the 19 wide. Always, I mean, every case of the widest implant that each manufacturer makes, depending on what disc I'm using, as deep as possible to get full end plate coverage.
Mm-hmm.
And I really
it just reinforces that arthroplasty surgery is harder than arthrodesis surgery. We can kind of be lazy when you're doing a fusion because you can depend on indirect decompression and stabilization and resorption. But when you're putting in a motion device, you got to do a good decompression. You got to do it bilaterally and symmetrically. And you really got to pay more attention. So, in the ProDisc IDE study, the neurologic success, the sub part of one of the primary success outcomes, was better in the ProDisc patients than in the fusion patients. And the surgeons were criticized. You guys are doing a better job on your investigational device. And the answer is, yeah, we probably were, but that's not a bad thing. It just means that it's more demanding surgery and that we were more meticulous about it. And I think that's the lesson for all of us. It's made us better fusion surgeons because I think we go back and do a better decompression now than we used to. But clearly arthroplasty will magnify the surgeon's sins and fusion will cover up some of them.
That's true.
Hey, there's a question from the chat room. Ken Yanamara asked a question or raised the point that patients with early OPLL may have progression with TDR. He said starting to see reports. I've personally not seen that, but anybody have any experience about that?
I've not seen that.
Early OPLL progressing with TDR?
I've not seen that.
Okay, Ken, if you can send us the reports, we'll take a look at them.
Yeah.
All right, Scott.
Well, that was
I think it's going to be interesting. I think you're absolutely correct that the more and more adoption that the centers that see a lot of arthroplasties are going to, I think a lot of surgeons aren't going to want to do revisions, but we'll see more revisions as time goes on, which is fine. I mean, we're starting to get some early literature, some early do's and don'ts, and we'll get, more knowledge as we see more revisions to do.
And we're seeing more and more. As more and more surgeons are doing the primaries, we're going to get all the revisions. And even lumbar. I mean, our vascular approach surgeon said, all you're doing is bringing me these really tough revision cases. I said, the easy ones are going to be done in the community.
But it's important to keep in mind with the big denominator of cases that have been done over the last 20-something years, we're still talking about such a smaller percent of revisions than almost anything else we do. So that's the problem. Talking for an hour about complications is, somebody can say, oh, this surgery's got a lot of problems. But in perspective, it's a much lower revision rate than just about any other operation that spine surgeons do, including just a Lamy disc.
Well, listen, this one slide that Scott showed, and it's worth reiterating. The revision rate for total hips and total knees at 5 years or at 10 years is considered to be 5%. We're seeing data of less 1% or a little bit more, perhaps a little less at 20 years, And we're seeing the same thing, the lumbar spine. So,
Yeah, right.
I mean,
Well,
it's really performing far beyond than what we thought.
Scott, that was an amazingly erudite discussion that you did. And thank you very much. I don't know what you've done with my partner, but we're very, very proud of you. So
That was
thank
great
you very
talk,
much.
Scott. Very
No, it was
well
fun.
done. Well done.
You guys have a great night.
All right.
Take
All right,
care.
you two have a great
All right,
day
you guys.
tomorrow, Scott. I know you will.
Bye, guys.
All right. Take care.
All
Bye.
right, good night.
Night.
Hey, Corey, you're going to put up the number for claiming the credits?
Yes, I am. Here it is.
Okay, there it is, everybody. Claim your credits. Thank you,
Thank
everyone.
Dr. Geyer.
All right, good
Thanks,
night,
Corey.
everybody.
Good night.
Bye-bye.
Bye.
Good night, Terry.
Bye.
Go to sleep, Dr. Mornay.
Yeah.
I saw that.